Okay now?
Yes,
Yes,
sir.
sir. Yes, sir.
Just
Full.
click the hide option, sir. Down below. Yeah. Hide. Yes.
Yeah,
Yes, sir.
this
Thanks,
should
sir.
be good now. Okay, sorry for that technical glitch. Okay, so yes, we were talking about antigen and antibody, right? So the most important thing is how do we detect these antigens or antibodies? Of course, by various serological techniques or methods which are based on either agglutination or neutralization, right? So these are the two techniques that we will come across when we talk about various immunohematological testing, right? Also, we need to be conversant with the term of immunogenicity. What does it mean? It means, or it refers to, the ability of an antigen to stimulate the production of its corresponding antibody in a person who lacks the antigen. So, not all antigens are immunogenic or potent. Some antigens may not be able to trigger an antibody response at all. Some will be able to trigger, but to a very small extent. But some are very, very potent and they will be able to trigger a very profound immune response. Next, what we need to know is the type of antibodies. So all of us know that we may have IgG, IgM, IgA, IgD, or IgE. When it comes to blood group antibodies, you need to really zero down upon IgG and IgM, these two types. Okay. So the points to note are IgG is a small molecule and it has a pair of heavy chains and light chains of amino acids, right? And so what it can do is it can just coat the surface of the cells, red cells. Whereas IgM, as we all know, is pentameric. It has got five such pairs which are joined together by a J chain, and it can directly lead to agglutination of the red cells. So IgG will lead to sensitization or coating, whereas IgM will lead to direct agglutination and destruction or lysis. So if in detail we have to look at IgM, they will agglutinate in the saline phase, right? They are pentavalent. Usually they are naturally occurring. So they don't need any, sensitizing stimulus. They do not cross the placenta because they are larger in size and they will react typically at temperatures between 4 degrees to 20 degrees Celsius. So most of our isoagglutinins or the ABO antibodies, anti-A, anti-B, etc., are of this IgM type, which are known as complete antibodies. Whereas when it comes to IgG antibodies, they react specifically at the IAT phase, that means at 37 degrees Celsius in the antiglobulin phase of testing. And they may agglutinate in presence of albumin or enzyme. They are generally monovalent and usually they are immune in nature. That means there has to be some stimulus that has led to the production of these antibodies, and they can very easily cross the placenta. And the best example of these IgG antibodies are the Rh antibodies, which we see or which we encounter in the hemolytic disease of newborn. So when we talk about blood group antigens, they are present on the red blood cell membrane, the external part of the red blood cell membrane, and the antibodies are present in the plasma. Okay, so antigen and specific antibody will react with each other. So what is the importance of this basic knowledge is knowing the compatibility between the antigens and the antibodies in the donor and the recipient. So looking at the blood group systems, the predominant one which we need to take care of is the ABO and the Rh blood group system, which I think all of you know. But there are also other blood group systems which have been discovered, and a few of them are really, really very, very clinically significant, like the Kell, Duffy, Kidd, Lewis, etc. So apart from the typical ABO and RH grouping today, we at least look at RBC phenotyping for at least the RH group, right? So coming back to the blood groups, matching the antigen and the antibody. So antigen are present on the red cells and the antibody in the plasma. So a group person will have A antigens on the red cells and anti-B antibody in the plasma. Similarly, a B group person will have B antigen on the red cells and anti-A antibody in the plasma. A AB individual will have both A as well as B antigens on the RBCs, but there will be no corresponding antibody. And the O group individual will not have any antigen at all, but will have both anti-A and anti-B isoagglutinins in the plasma. Now, what does this mean is whenever we face a situation for choice of transfusion support, we need to just go back to this basic information. And the golden rule to follow is that for safety of the transfusion, do not introduce any new antigen into the system, and also see to it that you are minimizing entry of any new antibody also in your patient system. So that is something which we need to follow, right? So therefore, since O group red cells have no antigens at all, they are universal donor cells. So you can pass on a O cell to A group, B group, AB group also. They have no antigens, so they will not add to any problem, right? Immune problem. Whereas when it comes to plasma and platelets, can you use O? No, because the antibodies are present in the plasma. So O plasma will be the most problematic, right? Because it will have both anti-A and anti-B. So as far as plasma and platelets choice is concerned, the AB plasma will be the first choice, right? So if you are giving O group platelets or single donor apheresis platelets, etc., you need to deplete the plasma before issuing it to a non-O group recipient. So this is the clinical application of this information. Next, let us talk about the H antigen. So, we all are very well versed with the A, B, and D antigen, the Rh system. But when it comes to H antigen, we may not be very sure. So, I would want to highlight that a little bit over here. So, the basis of the formation of all our A antigen, B antigen is actually the H antigen. And if the H antigen is absent, then technically A or B antigens cannot be formed. And this absence of H antigen is typical of Bombay blood group or Bombay phenotype, right? So this is something which you all need to know. So what happens in the Bombay phenotype? H antigen is absent, and therefore, if the antigen is absent, the corresponding antibody will be there. So anti-H antibody will be present in the plasma of that particular individual, right? So if you take normal O cells, A cells, B cells, or AB cells, they all will have H substance. And therefore, none of these will be compatible with the plasma or with the blood of a Bombay phenotype individual. Okay. So only red cells from another Bombay group individual are compatible. And that is something to bear in mind, because if you encounter a Bombay phenotype individual, it's very important for them to tell this information that in case of emergency, if they need any transfusion, we need to know another Bombay phenotype individual who can come and donate blood. And there is a registry of these Bombay phenotype donors at KEM Hospital in the National Institute of Immunohematology, which is situated on the 13th floor of the multi-story building, right? So please remember a little bit about Bombay phenotype, right? So for transfusion purpose, what are the choices? So if you have an individual who is A group, that individual can receive A group or O group red cells. So here we are talking predominantly about red cell transfusion. A B group individual can receive B group or O group components. An AB individual, in the order of priority, will receive A or B or AB or O. A O group individual can receive only O cells. A Bombay phenotype should receive only Bombay phenotype cells. A Rh positive individual can be transfused with Rh positive as well as Rh negative blood components. Whereas the Rh negative individual, especially if it's a female in the childbearing age, etc., then has to receive Rh negative components only, right? So we'll talk about Rh also in the subsequent slides. So when it comes to ABO grouping, we have two components, which includes cell grouping and plasma grouping. So blood grouping is not only just doing your test with anti-A and anti-B. There is a forward or cell grouping and a reverse, that is plasma grouping, right? So this is something which we all know. We have the reagents anti-A, anti-B, anti-AB, right? And these are the anti-sera that are used for the forward blood group, and for the plasma blood grouping or the reverse blood grouping, we will use these reagent red cells or pooled cells, which will be either 5% or 1% concentration. Okay, so if you are using automation, mainly less concentrated cell suspension is required, and if you are using manual methods like tube technique, then a little more concentrated, like 5% cell suspension will be required, right? So as I said, there is forward and reverse grouping. You do these two tests separately and then compare the results and then interpret the blood group of the individual. So for doing this blood grouping exercise, you may use the test tube method, the slide method, the microplate method. There are various automated methods, or you may have the column agglutination technology, right? So in the forward grouping, what do? We are testing the sample red cells with anti-A and anti-B to determine the antigenic type. Whereas in the serum grouping, we are testing the patient's serum with known A and B cells to determine which antibody or which isoagglutinin is present in that particular sample or that particular donor or patient. So let us consider these methods. So microplate method. So you can see that microplate is something like this. You know, all of us are aware of this particular configuration of the microplate. So it is used for testing batch of blood samples, large number of blood samples. It can be easily incubated, centrifuged, etc. And therefore, there is a lot of saving in time and cost of the disposables and reagents. So actually, when I was a student, we had a lot of microplate methods that were available. They can be reused after cleaning also, and actually it gives good results, and turnaround time is also good for batch testing, basically, right? So that is the microplate. More often now, most of the blood centers use column agglutination technology. So you will have a card which is like this, which will have both the components. So your anti-sera are also there, so forward grouping, and then you have the reverse grouping. So you have uh, various wells that are available or columns that are available for adding your uh, reagent red cells or your plasma, right? And then there may be within those columns there may be gel like material, so you call it gel technology, or glass beads and various other things, or even magnetic particles, etc., right? What is more important here is the grading of the results, because in the tube technique your grade of agglutination will appear separate differently, whereas here this one complete layer at the top of the column will be 4 plus agglutination. If there is some percolation into the material in the column, then it would be 3 plus. If that percolation of minute agglutinates is still the bottom, it is 2 plus. And if majority of the cells have reached the bottom and only a few minor agglutinates are there at the top, it is 1 plus agglutination. And no agglutination means all your red cells have traveled right to the bottom of your column, right? So that is no agglutination. Slide method, of course, is not a reliable method and not at all recommended. Most of the labs, basically pathology labs, etc., in private practice, they use the slide method and just do the forward grouping, but you cannot rely upon that as your final blood group results, right? So this can just be done as a counter check mechanism just before issuing blood or at the patient's bedside to ensure that no wrong blood transfusion is going on. And this is how the slide looks. So you have anti-A and anti-B, which is added one drop to the red cells, and you can see the agglutination. So if your anti-A is showing agglutination, the type is A. If anti-B is showing agglutination, the type is B, the forward blood group type. And if no agglutination, it would be type O. And if there is agglutination with both antisera, it would be type AB, right? So let us now look at the RH blood group system. Well, the formation of antibody against this Rh will happen only after exposure through either transfusion or pregnancy. So if some individual does not have the D antigen or Rh antigen, then unless and until he or she is exposed to the Rh antigen, that individual will not form an antibody. And does it form always? No. So even if a Rh negative individual is exposed to Rh positive cells, only in about 30 to 85% of the cases the anti-D antibody or the anti-Rh antibody will be formed. Not always, not in 100% of the cases. Now this is something that we should remember, because in life-saving emergencies, if suppose you have a Rh negative female bleeding, massive postpartum hemorrhage, and you don't have any other choice, suppose she is A negative, but you have A positive blood available, and you're worried about the Rh incompatibility, the worst that may happen is she may develop anti-D antibodies, right? But at least we can save her life by transfusing that after taking proper consent from her treating physician. Okay. So when it comes to Rh testing, we know that if Rh is present, the D antigen is present, then it will be Rh positive. If the D antigen is absent, then the type will be Rh negative. Okay. So world over, there is different proportion of Rh negative individuals. In India, on an average, it would be about 5% of our population, whereas in the Western world, about 15% of the population is Rh negative. So detyping can be a little challenging, and therefore, the most important things I have just highlighted over here. First is that you have to use two different anti-D types or lots, basically. So one of your anti-D reagent should be monoclonal and the other has to be a blend. So you use one IgG plus M type and one only IgM type of anti-D and look for agglutination. If your agglutination is greater than 2 plus grade, then it is definitely a Rh positive case. If it is less than 2 plus grade, then it may be a D variant, either weak D or partial D, etc. So you incubate further and go up to the antiglobulin phase. And if the result is still positive, so you do a DU test, as we say. If it is positive, so if this is positive, then it is still a Rh positive, weak D positive, we may say. And if this is negative, then it may be a Rh negative individual, right? So we've already talked about the H system. The most important thing to note over here is that the O group, which has got no A and B antigens, it has got a lot of H antigen, H substance. So O has the highest amount of H substance, followed by A2, then B, then A2B, then A1 and A1B. Okay, so we have to remember this, especially in this era when we go for solid organ transplants and other things. So the blood group of the donor and the recipient is very, very important, right? So a O group individual as a donor can be challenging because he will have a lot of H substance, whereas the best donor would be A1B group actually, right? So Bombay phenotype, as I said, the forward grouping will be like O group. There will be no agglutination at all with anti-A, anti-B or anti-AB. And in the reverse blood grouping, you will get agglutination throughout with A cells, B cells, as well as with the O cells. Now, that is why doing both forward and reverse is very important. At centers where this is not done, a Bombay phenotype individual also goes with a O group card. You know, he's given the information that you are O group and not Bombay phenotype. So very important to do forward and reverse blood grouping. Okay, this is just a table for reference because you may have a typical Bombay phenotype. At times, these Bombay individuals may have some amount of A substance or B substance or some H substance also. So they are para Bombay phenotype, and there are some H deficient secretors also. So this is basically the difference in their anti-H levels and what are they secreting in their saliva, etc. I'll not go into the details, but this is just for you to know that apart from the Bombay phenotype, there is a non-secretor para-Bombay phenotype also and a H deficient secretor also. So all in all, what is the significance? Why are we talking so much about blood groups? Because they play a very important role in transfusion, especially when blood transfusion is needed, and not only in pregnancy or so, but also in any other clinical scenario where transfusion of red cells or plasma or platelets is needed, right? Also, we can understand the scenario where there may be a accelerated destruction of the red cells because there is presence of the corresponding antigen for which an antibody is already available in the patient's circulation, right? So unlike this ABO and Rh, the other blood group antigens are not tested. They are not detected routinely in the blood banks, and they but they are of clinical significance. So that is something which we need to understand. Now let us come to compatibility testing. So after blood grouping, the next step that we proceed to is looking for a matching solution which can be safely transfused to the patient. So what you do is you take the donor's red cells and you test them with the recipient's sample. And what you look for is ABO compatibility, D compatibility, and one more important thing is you also don't forget to detect any clinically significant unexpected antibodies, right? So let us try and understand what are these unexpected antibodies, right? So we have already seen that red cell allo antibodies will be other than the anti-A and anti-B. Anti-A and anti-B are naturally occurring antibodies or isoagglutinins, whereas unexpected antibodies will be immune antibodies. So they will be IgG type, and these will be produced after a immune stimulus, right? So why are they important? Because they will lead to destruction of the transfused red cells which may have the corresponding antigen. Okay. For example, in hemolytic disease of newborn, the mother is Rh negative, the child is Rh positive. The mother gets sensitized because of the feto-maternal circulation of Rh positive cells, and she develops anti-D, which will then cross the placental barrier because it is IgG type and go and start hemolyzing the Rh positive cells of the child, which is typically the picture in hemolytic disease of newborn, right? So the traditional approach to pre-transfusion testing will be when you receive your sample and the request. First and foremost, look for labeling errors because you are going to interpret the sample that you have received. But what if that sample itself is wrong? It is from the wrong patient. A wrong blooding tube can be disastrous. Even though everything has been done correctly, the end result of that transfusion can lead to a hemolytic transfusion reaction. So look for labeling errors. If there are labeling errors, then they need to be resolved and you need to get a new sample, right? But if everything is okay, then you can perform a ABO and a RH typing. If there is any discrepancy, again you need to investigate. But if there is no discrepancy, then you can do a cross match. So as a good practice, we always follow the principle that ABO grouping and antibody screening will be done with us the first collected sample. And if the patient is needing a cross match or a transfusion, then we request for a separately collected sample just to rule out the possibility of wrong blooding tube or wrong means mismatched transfusion reactions, because maybe the first sample was wrongly collected or wrongly labeled. If we do the cross matching also with the same sample, we will not have any chance to detect any labeling errors. Okay, so just for that purpose, see to it that you do blood grouping with one sample and cross matching with a separately collected and labeled sample, independently collected. Okay, so hemolytic transfusion reactions can be nightmarish. Actually, these do occur mainly because of human errors and not because of any failure to detect the corresponding antigen or antibody. About 70% of them still happen because of human errors. The correct cross matching was done, everything was right, but only when it went to the clinical area, the patient's A blood was given to patient B and something like that, right? So hemolytic transfusion reactions will lead to massive hemolysis and renal shutdown. So you all should be well conversant with how to take care of a adverse transfusion reaction. So there can be a immediate hemolytic transfusion reaction because there are corresponding antibodies which are going to destroy those transfused red cells. And most commonly this will be anti-A, anti-B antibodies, but some allo antibodies also, like anti-K antibodies, anti-JKA, FYA. So the Duffy kid antibodies and all can lead to life-threatening hemolysis. Also, there is a second type which is known as delayed hemolytic transfusion reaction. So if it is the first time that such antigens, foreign antigens, have entered into the system, they will just sensitize the immune system to produce antibodies. And the next time again such an antigen enters into the system, then those antibodies will now attack all those antigens, corresponding antigens, and lead to a delayed hemolysis. So the transfusion goes on well and the patient goes home, but after 5 to 7 days, when the antibodies are formed, the patient has signs and symptoms of hemolysis. That means increased bilirubin, and renal function gets affected, etc. Hemoglobin comes down and the direct antiglobulin test will become positive, right? Hemolytic disease of newborn, we've already talked about. So here, the thing I want to highlight is that most of the antibodies that are involved in hemolytic disease of newborn belong to the Rh group, right? So anti-little c, anti-capital E, capital C, anti-K, right? All these are the commonest causes of hemolytic disease of newborn, and therefore Rh phenotyping of our donor and recipient is very, very important, right? So what chances do we get to identify these unexpected antibodies? One is, you will notice a discrepancy in your cell and serum grouping, the forward and the reverse grouping. You will find an extra reaction maybe, right? Or when you do a cross matching or a compatibility testing, the cross match will be incompatible, which otherwise has to be compatible because you have chosen the same blood group, donor units, but it is still incompatible because there is a unexpected antibody. Or when you do a antibody screening, which is recommended, you will get a positive result, right? So what is antibody screening basically? So this is a methodology which we use using some standard screening cells. That means cells which have got known phenotypes, they are used, and the common antibody specificities can be detected. So you will have screening cell 1, screening cell 2 and 3, and you test the patient sample with these cells. If any of those cells or all of them are positive, that means the patient has got either a single or possibly multiple antibodies. Now, in which cases do you need to do antibody screening? Any patient who needs transfusion. So with the cross matching, you need to also perform a screening. So we call it type and screen. Antenatal women, also you need to perform antibody screening, and patients with suspected transfusion reactions, and also in your blood donor samples you need to perform antibody screening, right? Now, how will you detect these antibodies? The key process in pre-transfusion compatibility testing is actually excluding antibody or detection of these antibodies, right? Also for high risk infants, in case of HDN and all, you need to be aware of the antibody that is possible and its detection, right? So as I said, the antibody screening, there are group of cells. So you may have a 3-cell panel, which are all O group cells, so that there are no A antigen or B antigen, but only the minor blood group antigens are there. We know the phenotype, so that will be available in your antigram. And there will be some cells which will be having a homozygous expression of those antigens, for which they can detect the corresponding antibodies, right? So again, the methods here can be automated, semi-automated, or even manual, right? Now, the interpretation of your result will be based on the phase of the reaction. So are you able to detect the antibody at room temperature, or is it a auto-reacting antibody, or how many cells? As I said, it can be a single specificity antibody or antibody towards multiple specificities, multiple antigens also, right? The limitations are that you may detect only when the antibody levels are high. So you need to have a good strength of antibody to be able to detect by most of the methods. But new methods, the automated methods, are more sensitive now, and you will not detect antibodies against low frequency antigens. So these are the limitations to keep in mind. And when they are detected, That is just the first step. So you need to now identify what specificity this antibody is against, right? And therefore you will need a larger panel of cells. So we generally have a 10 or a 11 cell panel against which now we test the sample of the patient and try to find out whether there is a autoantibody or a alloantibody with any particular specificity. So that is known as antibody identification. So this is just an example of the antibody panel. Basically, you can see here, these are the cell numbers. So there are 11 cells and their configuration or the phenotype is mentioned over here. You note down whether you have noticed agglutination or no agglutination in the immediate spin, that is the saline phase at room temperature, and in the at 37 degrees Celsius, and in the anti-human globulin phase. So that is how we perform a antibody identification, and then there is a elaborate methodology of crossing out, ruling in and ruling out, etc. I won't go into the details of that, but you just need to be aware so that if you get any such challenging case, maybe you can refer it to a blood center for further resolution, right? So basically, apart from that, we can also do antigen typing of the patient's red cells. So suppose you have detected a anti-E antibody, then the final proof of principle is that you should be able to also demonstrate that the patient's own red cells are lacking the E antigen, because the patient will be able to produce an alloantibody towards a antigen that is lacking in their on their red cells, right? So that is the final confirmation that we do in the laboratory. So antibodies, alloantibodies, we are talking about nothing but alloimmunization. So there can be single antibodies or multiple antibodies, and multiple antibodies generally we see in cases who are multiply transfused, like thalassemia, sickle cell anemia, or autoimmune hemolytic anemia, where autoantibody as well as various alloantibodies may be present underlying those autoantibodies. And how big is the problem? It is about 3% in the general patient population, but in the multi-transfused patient population, it can be as high as 8% to 76%. And therefore, it's very, very important that if you know right from the beginning that you're dealing with, say, a thalassemia patient or a aplastic anemia patient who is definitely going to be multiply transfused, and 70% of these alloantibodies are towards the Rh group antigens. So give them Rh phenotype matched blood transfusions, and you will be preventing 70% by 70% the formation of these allo antibodies or the process of alloimmunization, right? So that is something which we need to know. Also, I talked about immunogenicity in the beginning. So you should know that the D antigen is very immunogenic, followed by the little c, capital E, capital C, and the least immunogenic is little e. Also, the Kell system will also be rated as second only to D in its immunogenicity, right? So when you do Rh-Kell phenotyping, any K negative, so most of us will be Kell positive. But if you identify some Kell negative individuals, which can be about only 1 to 2% of our population, then you have to see to it that you transfuse only Kell negative units to this individual, because by chance, if a Kell positive or K positive unit goes in, then the chances of developing an anti-Kell antibody is very high. It is to the tune of 10%. So that is something which you need to understand. The last part is about direct antiglobulin test. So this is again a very commonly requested immunohematology test. So you should also know that direct antiglobulin test is used to differentiate alloantibodies from autoantibodies. So if there are alloantibodies present, the DAT is generally negative, whereas in the presence of autoantibodies, the DAT will be positive. So your auto control also will be positive. So mostly, why do we do direct antiglobulin test? We want to see whether in vivo within the circulation there is coating of RBCs with any antibody, any IgG antibody, right? So here anti-human globulin is added to the washed patient's red cells to determine the direct antiglobulin test. And a positive test can give you some information, as I said, if the patient has been transfused then the patient may have an allo antibody coating the transfused cells. And if the patient has not been transfused, then the patient may have an auto antibody coating their own cells. So the history of transfusion is very, very important when you are dealing or when you are testing some patient sample for direct antiglobulin test, right? So that was about immunohematology. Now, in just 5 minutes, maybe before I complete, I'll just touch upon the testing for transfusion transmissible infections. So, as you all know, the transfusion transmissible infections are the triple H, that is hepatitis B, hepatitis C, and HIV, which are the viral TTIs, and the non-viral TTIs that we test for is syphilis and malaria, right? So, but are these the only ones which are organisms of concern? No. So if you look at the list of organisms that can be transmitted by blood, they are a lot many. But of course, it is not possible for anyone, rather, not none of the countries really do test for all the possible organisms. So each country has got their own regulation. They test for the most common organisms of concern in their geographical location. We also should know the concept of window period. So window period will be the time interval between the donor becoming infectious and the infection being detectable. Okay. So you may not be, your test may not be able to detect an infection, but the donor has the viral antigens or viral particles and is able to pass on that infection. So that is nothing but window period transmission. And that is the risk of transfusion basically. So if you are using a simple test like a card test, which is not very sensitive, neither specific, then the window period is large, and the possibility of such tested blood, you know, with rapid test, etc., transmitting hepatitis or even HIV is larger than blood which is tested by a good fourth generation ELISA or a chemiluminescence assay, etc. Okay, so all we need to know is that when we deal with blood components, all these are tested by tests which are screening tests. They are not confirmatory or they are not definitive tests. Okay, of course, now we have the nucleic acid amplification testing, the molecular testing for hepatitis B, C, and HIV, and that can be quite useful, and it has narrowed down the window period of transmission to a few days. So for HIV, it has come down to as less as just 3 days, right? So basically, what strategies we use for TTI prevention is careful donor selection. Though you have the best test available, if your donor is truthful and he is revealing all the high risk behavior, etc., then there is absolutely no risk of transfusion transmissible infections. So, as I said, the tests that are mandatory as per the Drugs and Cosmetics Act are these tests: the HIV 1 and 2, hepatitis B, hepatitis C, malaria, and syphilis. Okay, and the technology that is used most commonly even today in India is the ELISA testing. So this is again the uh, microplate ELISA, where we have positive and negative controls and external control and a blank, and then you have your donor samples. So that is how you test, and you take the reading finally with a spectrophotometer, and based on the optical density that is measured, you have your negative and positive control and 10% cutoff, and then you define the values for your reactive and non-reactive samples. Okay, so what is important is doing a proper quality assurance of these tests by using a external positive control. So you have various licensed kits that are available, but the problem in India is that there is no uniformity in testing. So you have a spectrum of kits available, from the basic kits to the best possible kits, and therefore blood safety can vary from blood center to blood center, from region to region, from city to city, etc. Because you may have a rapid testing mechanism like this, or you may have ELISA like we saw. So the test that your blood center is using is very, very important as far as blood safety is concerned. Also, I have just shown one of our cases here where malaria, we are endemic for malaria, and transmission of malaria by even blood donation today blood transfusion is possible. Plasmodium vivax is most of the times involved in this transfusion transmitted malaria. And syphilis, of course, though we don't get such transfusion transmitted syphilis cases these days, but still we continue to test because it is also a surrogate marker for high risk behavior. So we do VDRL or rapid plasma reagent testing in the blood center. So it is based on the flocculation principle. So you can see flocculation if it is reactive, and a non-reactive result will look something like this. Okay, finally, a word about NAT. As I said, it is the molecular test that is used for detection of viral RNA or DNA, and it significantly reduces the window period for the potential infectious window period for transmission, and therefore, the best possible test is NAT test for ensuring blood safety. Of course, as I said, nothing can replace a truthful and a responsible donor. So, having a good donor base is the most important thing. So, that's it, friends. That's about transfusion testing, mainly focusing upon the immunohematology. So, I hope I have given you a broad understanding of the ABO